Hi everyone, welcome to the fourth episode of Henry Schein's COVID-19 webinar series. I'm Dr. Gary Severance. And as you all know, there is a resource page, henryschein.com/COVID-19 update, but there's a new addition now. Henry Schein Financial Services has added a CARES Act landing page to help all dental professionals register and look at financing options. Now let's turn to Dr. David Reznik for our clinical update. Dr. David Reznik is the director of the Oral Health Center of Grady Health System's Infectious Disease Program. Thank you, Dr. Reznik, for joining us once again.
Thanks, Gary. My name is Dr. David Reznik. I'm Chief of Dental Medicine at Grady Health System, and I'm here to do a few things today. One, I would like to answer some of the questions that have come in, and two, I'd like to talk about the newest guideline from OSHA. So let's go ahead and get started. OSHA came out with an enforcement memo and an interim guidance that really is about how we're going to take the best advantage of using our masks, our N95 masks. So what steps do we make sure that we're actually following what OSHA is using? And as I've mentioned before, and you've seen in the literature at this point, when we're doing aerosol generating procedures, we need to have on an N95 mask or an N95 respirator. And these are very important. But if you don't have them, there are alternatives that you can use. But if you see the picture on the right, which is a powered air purifying respirator, otherwise known as a PAPR, you can see that that might cause a little bit of difficulty when trying to perform routine dentistry. So our goal is to be able to access N95 masks, as well as then be able to protect them and to reuse them. So there are a few things that are really important about reusing. First, don't write on an N95 mask. That will actually hurt its function. So if you have your own personal, get a paper bag and put your name on the bag and then store your mask in the bag. That way you can keep it for further use. And we're talking about in situations like we are now where there's literally a shortage of masks that are available. So that's why OSHA has approved some recommended changes, like if it's past its shelf life. If you look at the date and in the hospital environment, we're very temperamental about these dates. If it looks like it's going out, we toss it. Well, what we're finding out on these N95s is that they are functional, very functional, past the date when they're supposed to be a good buy. So it's something that you can use or reuse. When we're talking about N95 shortages, the federal government has specific manufacturing recommendations that are put in for the shelf life. Again, I'm trying to stress the point that you can use them past their shelf life date. NIOSH has tested a bunch of N95s that are beyond their manufacturer's recommended shelf life, and they determined that these models continue to protect against the hazards for which they would ordinarily be appropriate. And so what we're talking about is they need to be able to filter out 95% of the particles of the most penetrating size, which is 0.3 microns. The other kinds of masks that we talk about, say a level 3 mask, that's really good at fluid protection, but doesn't have the same kind of particle protection, which is why you need those N95 masks. You may have heard me talk in the past about protecting them. So in the dental office, if you have to do an aerosolized procedure, we have shields that you can place, and that will protect you from fluids. If you're afraid that the shield isn't going to be sufficient, you can always wear a level 3 or a level 2 surgical mask over the N95 just to protect the mask. That's the only reason you're doing it. You're not adding any more benefit. When don't we want to use expired N95s? Literally when we're talking about procedures that generate aerosols, or procedures where we have our ENT friends and our pulmonology friends where you're doing things such as extubation, bronchoscopy, or even CPR. So that's probably not a time when you'd want to use an expired device. In dentistry, since we're very limited and we have limited access, this is one time where I would say using an expired N95 is much smarter than using a level 3 mask. The same person same individual can use a mask multiple times. And as I've mentioned, please don't write on the mask, just write on the paper bag to store them. But as long as the respirator or as long as the N95 maintains its structural and its functional integrity. So again, it can't get wet, it can't be written on, it can't be smushed. We really want to get these things fit tested so you get a nice tight seal. And they come in 3 sizes. So it's important to realize that small, medium, and large are basically what we look like, but we need to get them where they're sealed and get them fit tested, which again, I think is going to be something in the future of dentistry. It's something I've been doing at a hospital for the last a quarter of a century, but not something I was doing in private practice where I was before. So when we look at how dentistry is changing, how we look at PPE and how we look at masks, all these things are going to change. Extended use is preferred over reuse for contact transmission. So, because one of the things about reusing and taking off and on is how are we taking our materials, our PPE off correctly? Are we putting it on in the correct order? And so we'd like to keep it on as opposed to taking it on and off as many times as possible. And we also need to look at proper storage just to make sure that we're keeping the mask as healthy as possible, because the goal is to keep the dental team as healthy as possible as well as those that we serve. When we talk about PPE for preventing contamination of patients, we have been at the forefront of personal protective equipment basically since the HIV epidemic. So we really know how important hand washing is. I think everyone knows how long 20 seconds is now. But it's not just the mask that's important. It's making sure that you have all of the components of your personal protective equipment that are on. They're on appropriately. The collar is buttoned all the way up to the tie. You're wearing eye protection and eye control. And so these are certain things that we want to make sure that we're following, just not to pay attention to the mask, but every aspect of the personal protective equipment that we use on a daily basis. One thing I'd like to add is a recent study was just published in JAMA suggesting that the air contaminated with COVID-19 might travel a little bit further than what we've been told, even up to 4 times as far. And so I think the point the authors were trying to make is that we don't have an invisible 6 feet wall around us. We have different people around us. We have people that can really sneeze or let off a cough or whatever. And so the distance can be a lot further than that 6 feet. Am I saying that we should stay further apart? No, by no means am I saying that. I think we just need to be aware of our surroundings, be aware of the conditions, and be aware of what the risk and benefits are. Another question that comes up is about, well, we might be treating for dental emergencies either asymptomatic, or a new term that's popped up, pre-symptomatic COVID patients in our office today. And so we've looked, and there are studies that looked in Singapore, there are studies that have looked in Chinese areas, and even studies that have looked in the U.S., and we found that it could be up to 12.6% in China in one study, where they found the transmissions could have occurred before symptoms showed up. I've seen numbers as high as 17% in some studies, and some studies as low as in the 4s. So the bottom line is that we'll treat asymptomatic patients. They'll be coming into our office until we have a vaccine. Following your PPE is very important. Just like with bloodborne pathogens, just like with standard precautions, we look at every patient as having a bloodborne pathogen. We don't treat anybody differently. I think in our new reality, until we have a vaccine, we're going to have to treat every patient as if they potentially have this infection. Now, we know that's not the case, but we have to treat everybody the same in order to protect our dental team, our patients, and family and friends. A question that came in that is sort of interesting, and there were several of these questions. So when I address one, it's not that I just got one question, we got a bunch of them. Does the air in the operatory need to be sanitized after each patient? So for patients receiving emergency care not involving an aerosol generating procedure, routine post-visit infection control issues that you would do should be utilized. So you're going to wipe all your surfaces down, you're going to change out your plastics, you're going to do your waterline maintenance, you're going to do everything that you would normally do. As far as treating air, I'm not exactly sure how we treat air. We can treat it through UV. Some people are doing that, but that's not really practical. In the new program that I'm setting up, I am setting up a negative pressure room, which again is not very practical for a general dentist or specialist in the private sector or even in community health settings. It becomes difficult. So I think we really need to learn what we can and can't do and what is probable and what's not probable. So as long as you're using an aerosol generating procedure, you need to have high speed evacuation going on. You need to have your N95 going on and your lab coat, and you had to wash your hands before you got into the room, and you sanitize your hands when you take your gloves off. You should have your N95 or higher respirator. Don't forget the eye protection. Eye protection is remarkably important when it comes to disease transmission, as well as protecting our patients from incidents that may occur. You should limit the number of providers in the room. This might not be the time you want to show residents or other faculty members or other dentists and your staff how you're doing certain procedures. You want to basically limit who's in there. If you can have an air exchange, which again is not typical in most dental settings, air exchanges can be quite helpful, and we are doing that in the new clinic. And then you need to have clean and disinfectant procedure room surfaces promptly. So clean them right away as described on environmental infection control. So follow your standard operating procedures. Spraying any kind of Lysol type product is not going to really benefit. It might make the room smell nice, and it is antiviral, but to this knowledge, there's really no treatment for the rooms. But it is important to maintain your routine cleaning and disinfecting procedures. You need to have EPA registered hospital grade disinfectants if you can. Most of the dental wipes that we have do work. I do have a link in here that you can click on, and you'll get the EPA website with all the EPA registered disinfectants that will work against SARS-CoV-2 or COVID-19. So you want to make sure you're using the right equipment, the right procedures, and always follow the manufacturer's directions. If it says the wet time is 2 minutes, that means 2 minutes. You might have to use more towels. We're running out of a little bit of the smaller towels and using bigger towels now, and it's easy to keep the wet time, but you have to change from using maybe 3 or 4 like we did before into using one that's going to take care of the whole area. So it's a little change in how we do our work.
Thank you, Dr. Reznik, for that updated clinical information. I'd like to turn now to our next guest, Dr. Charles Blair. Dr. Charles Blair is CEO of Charles Blair & Associates and offers numerous resources to increase profitability and to improve patient care. Today, Dr. Charles Blair shares with us effective utilization of teledentistry, not only during this time of COVID-19 crisis, but how we can implement it long-term in what will become the new dental experience. Thank you for joining us today, Dr. Blair.
Well, thank you very much, Gary. And I'm Charles Blair, Dr. Blair in Charlotte, North Carolina. I'm really pleased to work with you today and to give you an update on the coding for teledentistry. So let's get into the slides. I'm going to do this at a fairly fast pace. I would ask all of the listeners to probably listen to the presentation a couple of times, and I've tried to greatly simplify something that can be very challenging. So let's look at the slides. First, a disclaimer. This is for informational training purposes only. Of course, I'm not an attorney, and so for legal advice, consult a healthcare attorney. Also, the coding, we certainly have researched this, but just remember that statements that I make don't necessarily apply to all plans. There's just such a great variation out there, and there's no guarantee that a given plan will reimburse along the guidelines presented. And for the doctors, it's always code what you do. That's the ADA mantra. So follow the current CDT code set exactly to the best of your ability. So first, a warning. Wow, this webinar is current. It is a real changing landscape. Also, the ADA website, and I'll give you that as a reference. They have a website that's updated almost on a daily basis as far as the coding, and it's more along the lines, it does have coding, but it has what the various companies are doing as of today, so to speak. So be sure that you check with the ADA website as far as kind of the latest of some of the various companies. What's the objective today? Well, it's to simplify coding and reimbursement and decrease the confusion that is regarding teledentistry. And I think I've been able to really simplify this today, and we've got roughly 30 slides or so to go through. So, what codes might apply to the virtual appointment where the doctor calls the patient, engaging in dialogue? What particular codes might apply? We have two codes for teledentistry. 9995 is a real-time encounter. The other is where information is stored. The one you want to focus on is 9995. So there are two teledentistry codes, but 9995 is the one that applies to the interaction between the doctor and the patient. Which teledentistry code applies to the interaction between the patient and dentist? And again, 9995. So how do we put this on the claim form? And this is very, very important, because when the claim form goes in, we've got to place 9995 on the line below the service rendered, i.e., we might put down the emergency problem-focused exam, and that would be D0140 plus D9995. And so we're going to put the D9995. Now, insurance companies are picking up this code. And later, when we get into how many exams are allowed and so forth, some of the companies, if you put down the D9995 and you charge for a emergency exam insurance-wise, it might not apply to the overall limitation. The second part on the claim form that's different is we've got to change the place of service. Every claim that goes in by default with your Dentrix right now, the place of service is 11. There's about 80 place of service codes. For instance, the hospital, an outpatient clinic, a nursing home, or a dental office. The dental office place of service is 11. So the place of service, though, for teledentistry is 02. So we must change box number 38 on the claim form so that the place of service is now a 02 instead of the traditional 11. What about charging a separate fee for this teledentistry code? Well, the short answer is that a fee can be charged, but currently the reimbursement by payers is extremely low. Plus, is it piling on to even charge a fee? So stay tuned, because we're going to cover this later in the fee strategy conversation. So I'm going to give you the codes. Then the question is, do you want to charge for that given code? How is it reimbursed? What might be your cost? So we're going to go greater in detail later about strategies for how we might charge for this. Is there an evaluation code available to report? Yes. The ADA website lists several possible evaluations. The big one, the one I want you to remember, is code 0140. That's a limited oral exam. It's problem focused. Another code would be possibly a reevaluation. If you go back to talk to the patient again, and it's an established patient at that point, again, the ADA is giving us some alternative codes. The one I want you to focus on again is code 140. Also, 171 is a reevaluation, post-operative, almost always no charge, and that's a no charge. So I did want to show you, though, because there's confusion out there, there are several codes that could apply, but there's one code that's what I'm going to call the winner. And the winner is code 0140. So, is one of these procedures superior for best reimbursement coverage overall by most payers? Is there one that has a higher UCR than other valuations? Yes, there's a superior code. The winner, code 0140. So that's a limited oral exam, is problem focused. This is the winner in teledentistry overall. What are the typical limitations for evaluations? Well, typically, most plans would pay for 2 evaluations per year or 1 per 6 months. That's generally what's out there. So commonly, it's 2 exams per calendar year, doesn't matter which exam code it is, or 1 exam per 6-month period. Now get this though, there is a very few that may cover 2 emergencies plus 2 routine evaluations. Plus, I've already told you that when teledentistry kicks in here, when we put in a 140 with the teledentistry code, it might not be subject to these limitations that we've shown you here. So with the virus, what are the current limitations then? So it's a changing ball game, to say the least. A few plans, payers, have waived these traditional limits and now cover for additional evaluations. An additional evaluation may be 1 or possibly multiple. Again, I can't emphasize enough the variation from one company to another company. What other code has been mentioned for teledentistry consideration? There is an additional code. It's code 9992. It's dental case management. It's care coordination. As it says on the slide, assisting in a patient's decisions regarding the coordination of oral health care services across multiple providers, provider types, specialty areas of treatment, healthcare settings, healthcare organizations, and payment systems. This is the additional time and resources expended to provide experience or expertise beyond that possessed by the patient. So this would be the code to put on the claim if the dentist has consulted, say, with the patient's physician, and that takes time. That is an interaction. So what about this code? It is a possibility, but this code, as far as reimbursement, is way, way down the totem pole. So this reports a consultation between the dentist and the patient's physician. Very little coverage. The trend does not appear to be positive for coverage at this point. If you look at the ADA website where they list various companies, various codes that are covered, you're going to find that there's just very, very few coverages, at least of this code at this point, and we do not see a positive trend, but who knows? Stay tuned. So what about the summary of the codes? I've covered the best codes to report that are based on reimbursement and UCR. The ADA, its code committee, and all the codes, they cannot give strategies. They can give listing of codes, things that apply. I have the freedom to actually say, well, which code though out there, which of these codes might have the better reimbursement, which ones might have the better UCR. And again, code 140 is that winner. Now, let's get into the philosophy. What about the philosophy of charging patients for these various teledentistry reported codes? This is a personal decision. Well, the best code overall to charge the patient, which of these several codes that I've looked at and explained today, which one overall would be the best one? Again, code 0140 is the best bet. The coverage trend is actually improving, and we're seeing that some payers are increasing that frequency limitation from the common 2 per year or 1 per 6 months common limitation before teledentistry has come into play. Should you even charge for this code? Well, for long-time patients, some dentists may be reluctant, but keep in mind that insurance reimbursement is very good for this code. And so for new patients, some dentists may charge. It's your choice as to charge your standard fee. And so again, the reimbursement levels, the UCR levels for 140 are very, very good compared to the other codes that might be possible. Related to teledentistry and the virus and so forth, what about giving or forgiving copays and deductibles? This is optional. On the medical side, with this teledentistry and these exams over the phone, so forth, in the medical side of the coin, there's deductibles and copays. On the dental side, we don't see much of that. I did want to mention, though, that the Office of the Attorney General, OIG, they have said that temporarily for teledentistry codes, we're talking just the teledentistry codes, that copays and deductibles can be forgiven. Again, this doesn't apply to the dental side very much, but I did want to bring that out. If you run into a copay and deductible, that could be forgiven of the patient, specifically for the teledentistry claim form, the codes on that. What kind of technology is allowed? Well, non-public communication platforms allowed would be smartphones, Apple FaceTime, Skype, Google Hangouts, Zoom, Facebook, Video Messenger. What could the doctor not communicate to the patient through? Instagram, Facebook Live, TikTok. Also, you should get an informed consent and do an informed consent with the patient that it's okay to do this with them with teledentistry. The Office of Civil Rights has stated that it will waive potential HIPAA penalties for good faith use of telehealth during this nationwide emergency. And you can see about that. So the bottom line is they are opening it up to where you can communicate by telephone and so forth without necessarily being 100% HIPAA compliant. So these technologies are okay that we have gone through at this point. What about charging for 9995, the teledentistry code? Well, it's typically not covered, but a charge is permitted. So there's very, very limited coverage at this time. We're hearing, if it is covered, fees around $12 to $15 for the teledentistry code. Another consideration, though, is it kind of piling on to charge a fee for 9995 plus code 140? So it's an individual decision. The dentist will have to decide if a fee is charged for 9995 in addition to D0140. Even at the $4 cost, that's a pretty nominal cost. So it's up to the dentist to decide, again, strategies for charging for 9995 in addition to code 0140. What about charging for this dental case management fee, the 99992? And this is where we report this code as an extra charge to the patient for the dentist consulting with the patient's physician. At present, it is rarely covered. If you notice, I underlined rarely. Looking through a big list of codes as to their coverage with a pretty big list of companies, it's just rarely covered. And so again, does the dentist want to charge this additional fee? Is it piling on to charge 99992 plus code 140 plus 9995? So again, a decision of the practice and the dentist. So at the end of the day, the dentist must decide the appropriate charge for the most appropriate situation. A couple comments about documentation. You want to enter in the patient record that you did the teledentistry code, the appropriate service rendered, code 140 and so forth. You want to record aspects of the audio conversation and any provided by the patient to conduct a problem-focused exam. Possibly the patient sent you a picture, maybe of a lesion in their mouth or swelling or whatever else it might be. So again, in record keeping, document the reason for the encounter, the diagnosis, the condition of the patient, and this establishes the emergent need for telehealth. So store in a secure location any transmitted photos that would be an assistance in their diagnosis and treatment. So just a couple of things here. I wanted to remind you that Henry Schein has Practice Booster available. You see the item code for that. We've also got the Code with Confidence book, the item code. The administrative book is chock full of administrative items on how to deal with PPOs, how to deal with the administrative side. And frankly, you're going to find very few of these books in your territory. Very, very few. And also Schein has the bundle package there. So a pleasure to bring this to you today. And I did want to mention that we do have the medical cross-coding manual. It's a monster. It's 800 pages plus. And so that is a monster. So I'll leave this slide up at this point as I have my closing comments. Again, thank you for your participation. I would highly recommend that you replay this presentation for a second time, possibly a third time. And I've tried to really focus on the codes that are payable. I tried to focus on as far as how you might charge for these today. So I thank you very much, and thank you for listening in to the presentation today.
Thank you, Dr. Blair, for that great information pertinent to not only dental professionals, but their patients as well. If you have any questions or concerns, please email us at webinars@henryschein.com, and please subscribe to the Henry Schein YouTube page to get notified of new and relevant content. Thank you for spending your time with us today. Stay safe and stay informed.